Dr. Who is a professor of medicine at the Icahn School of Medicine and the director of cardiology consults and the director of cardio-oncology program at Mount Sinai Hospital. The cardio-oncology program at Mount Sinai Hospital was established in 2013 under the directorship of Dr. Sahni, and she was awarded the Gold Center of Excellence in July 2022. This is the highest designation of certification than the International Cardio-Oncology Society, the largest international platform for physicians and nurse practitioners dedicated to cardiovascular care of cancer patients. Mount Sinai's cardio-oncology program was the first in New York State to be awarded the coveted gold status as a cardio-oncology center of excellence by ICOS, acknowledging exceptional cardiovascular care of oncology patients. It is my pleasure to introduce Dr. Sahni, who today is going to be talking to us about cardio-oncology and critical care updates for 2024, which is a really exciting topic since I think all of us are seeing more and more of these patients in our ICU, both with cancer getting these new novel medications, as well as some of the complications that are coming in from these medications. So without further ado, thank you, Dr. Sahni, for coming and talking to us.
Thank you, Evan. Thank you, Dr. Gilvani, for the invite. And as I know, I get a lot of consults from the ICU, and I will try to touch and update a little kind of like a buffet of all the cardiotoxicities that you most commonly see, including the challenges as well as the objectives of this talk would be basically not just the mechanisms of basic cardiotoxicities that we come across, but more targeted towards the audience today, which is the heart failure, myocarditis, acute MI, and arrhythmias that you see in the intensive care units, and the cardio-oncology emergencies, which come across from cardio-oncology. So to open up a Pandora's box of cardiotoxicity, I know cardiotoxicity earlier was synonymous with just anthracyclines and heart failure, right? And we know the usual culprits of heart failure being anthracyclines and trastuzumab, and some of our smaller tyrosine kinase inhibitor molecules. But I will be opening up a little bit bigger Pandora's box of cardiotoxicities and also acquainting this audience with the current definitions and mechanism of cardiotoxicity. And the two kind of words that I'll use very often are CTRCD and CTRCD, not because I want to use them, but because the ESC guidelines from 2022 use these definitions of CTRCD and CTRCVT. So heart failure from cancer therapeutics, as we know it, has been given the designation of CTRCD. So a lot of cardio-oncology data as well as papers will be using this term very often. And it basically stands for cancer therapeutics related cardiac dysfunction. So whether it's systolic or diastolic heart failure or myocarditis, anything affecting the cardiac function as such in terms of the muscle will come under the broad purview of CTRCD. And CTRCVD would be the entire other gamut of cardiotoxicities relating to MI, pericardial syndromes, arrhythmias, hypertension, etc., would come under the broad umbrella of CTRCVT, which would be cancer therapeutic related cardiovascular toxicities other than CTRCD. So a lot of what I will cover, it will be from the most comprehensive cardio-oncology guidelines that we have so far. And you might say, well, why do we have to follow Europe? And really, this guideline was actually a beautiful piece written by 102, not just cardio-oncologists, but oncologists, oncosurgeons, radiation oncologists that got together from 105 countries to write these guidelines through COVID, and they were finally published in 2022. And so far, the most comprehensive guidelines that we have, maybe not covering everything, but the most in case you want to use a one-shot go-to for guidelines related to cardio-oncology. So I'm going to dive right into what is CTRCD, as I said, and that's divided into whether you're symptomatic or asymptomatic. So anytime there is a decline in LV function, so the decline is very mild and the patient is asymptomatic, or there's just a decline in strain, it would be mild asymptomatic CTRCD. If the EF is declined between 40 to 49%, or a decline by more than 10%, that would come under moderate. And severe would be a decline of EF to less than 40%. So these are most of the patients that we will see in the clinic and not be your patients. So let's jump into who your patients are going to be. Are probably the very severe and severe symptomatic CTRCD, those who are presenting with clinical heart failure. And these would be those who are requiring inotropic support, mechanical circulatory support, transplant, or are just needing heart failure hospitalization in your units. And most commonly, of course, we have anthracyclines on top of the list, but let's not forget the HER2-targeted therapies, which is just not trastuzumab, but the other newer HER2-targeted therapies, checkpoint inhibitors, 5-FU and the fluoropyrimidines, proteasome inhibitors, small targeted molecules like the VEGF inhibitors and the BCR-ABL inhibitors, which are used on leukemias and lymphoma patients. Post-bone marrow transplant CTRCD is rare, but also reported and seen. I will touch a little bit on CAR T-cell therapy and what we have to look out for and how to prevent it, and rarely acute myocarditis as well as cardiomyopathy from mediastinal radiation, which again is very uncommon. So jumping right into anthracyclines, I'll share the data as well as give you a little blurb of this patient. So this is Mrs. Ant, and sorry for being very cheesy about the patient monikers that I'm using here. So anthracyclines, this patient, Mrs. Ant, is this 58-year-old female with hypertension history, a triple negative metastatic left breast cancer, who was in the past, in 2017, had received doxorubicin 4 cycles with cyclophosphamide. And just to give you a gist, usually the combination of this exposes the patient to about 240 milligrams per meter square of doxorubicin. And now, unfortunately, she's developed a second malignancy that needs her to be using anthracyclines, and she's got uterine adenocarcinoma. And she was lost to follow up for about 6-7 years, and now the baseline echocardiogram before needing to use anthracyclines again for her second malignancy is showing an EF of 40%. With a GLS or a strain of -15, a BNP elevated 147. She's got mild heart failure symptoms. She's not in heart failure. She's got this usual fatigue. She had a normal echo back in 2017 with no testing since then. And now oncology wants to use an additional doxorubicin for a cumulative dose of 480 milligrams per meter square. And as you can see, the EF is not great in the intermediate HEF-MEF category, if you might say so. And so the question here is this CTRCD? And why am I giving you and belaboring you with the doses of all this chemotherapy, right? It's bad enough remembering the names. Why do we have to go into doses of this chemotherapy? And would you re-challenge, would you clear this patient for doxorubicin a second time, or shall we just absolutely refuse, right? And is there any role for GDMT that we use in heart failure, for particularly these patients that have developed, if we call it anthracycline cardiotoxicity? And in addition to GDMT, which we all in this audience are familiar with, is there any additional cardioprotective treatment which is particular to anthracyclines, and how should we monitor this patient subsequently? So again, coming back to, I'm showing the slide again, so clearly this patient is coming into probably the moderate to severe symptomatic CTRCD, right? So she's not completely needing heart failure hospitalization yet, but she's definitely needing outpatient intensification of diuretic and heart failure therapy. And this is why the doses are so important, right? So the doses are important because not only doxorubicin is dose-related cardiotoxicity, where most of the cardiotoxicities, and I know the slide says minimal but possible, but really all you need is one dose, and we've seen cardiotoxicity with just one dose of doxorubicin even. So any dose more than 0 is cardiotoxic in our world. But just as a epidemiological statistics point of view, it is a marked increase in cardiotoxicity as the doses that you expose these patients to go from beyond 300 milligrams per meter square. Nobody uses 700 milligrams per meter square anymore, but just do the math. The same patient who's received 240 milligrams, and now the oncologist wants to use another additional 480. Guess what? It will be approaching a cumulative lifetime dose. And here's why it's important. It's not individual doses. These doses are cumulative life doses. And it's important for us to know that, because a lot of our pediatric leukemia, lymphoma survivors have probably got doses about 200, 300 milligrams per meter square. But in their subsequent life expectancy, they might develop a secondary malignancy and they might require a second exposure to anthracycline. So it has to be a cumulative clock that you add on to the initial dose of anthracyclines that these patients have been exposed to. So this patient would come under the category of 700 milligrams per meter square of a lifetime exposure with an up to 48% incidence of developing heart failure, right? And also keep in mind that not all anthracyclines are created equal. And the reason I'm showing you this equivalency data, and you can actually punt into this, actually an MD calculator as well as an oncology calculator, that if the oncologist said, well, hey, I'm not planning to use doxorubicin, but I want to use daunorubicin, or I want to use idarubicin in case of hematological malignancies. And you're like, well, I know doxo doses. Dr. Sahni showed me the slide of, greater than 300 milligrams per meter square is a bad guy, but I don't know if idarubicin is such a bad guy. And really, not all anthracyclines are created equal. So if you look at the relative cardiotoxicities, if doxorubicin was, say, the really bad guy with 100% cardiotoxicity, the lesser bad guys are probably epirubicin, daunorubicin, mitoxantrone. It's probably worse, and idarubicin with the same dose is probably in this equivalent cardiotoxicity. And so there's actually a calculator, and you put in the dose of the intended anthracycline, and it will tell you the equivalent doxo dose. And then you can come back to the slide and say, okay, well, this is going to be an equivalent doxorubicin dose of 400 milligrams per meter square, et cetera. And this is a possible cardiotoxicity of this much developing. And not to forget that, remember, I showed you that this patient also received radiation to the left breast for her first breast cancer in 2017. And so this is not just dose related or the cumulative dose of anthracyclines, but the additional risk that radiation to the left breast, or say if this patient was an esophageal carcinoma patient who received mediastinal radiation, you have to factor in that additional risk of radiation. And this is from the ESC guidelines that I showed you, the 2022, which gives you a very good risk calculator. And if you see her, that even though her initial dose was 100 was just a not in the high risk category because it's 240 milligrams per meter square. Just the fact that she received radiation, and because she was left breast, she probably received more than 25 gray units to her mean heart dose to the left breast when she was getting radiation to the left breast. This puts her, even with a doxorubicin dose of greater than 100 milligrams per meter square, she would have automatically come into the very high risk category. So this is a patient who should not have been lost to follow-up since 2017, and she should have been told that, listen, not only did you receive doxo, but a dose of radiation that puts you in the very high risk category, you need cardiology follow-up and risk stratification. We probably would not have missed the interim decline in LVEF, but also not facing the clinical conundrum of whether we can expose her to a second dose of anthracyclines. And the HFAI costs, baseline risk stratification tool really gives you a very elegant tool of not just the clinical risk assessment and the test to order, but how to risk stratify not just anthracycline patients, but anybody with potential cardiotoxic chemo before, during, and after risk factor stratification, and how often and with what we should be monitoring these patients. And here is why this risk stratification tool is important, especially for anthracyclines, is because we've seen since the early studies from the 2000s, because remember, we've been using anthracyclines since 1965, the earlier we detect and treat doxorubicin-induced cardiomyopathy, or CTRCD, the better options we have. And traditional teaching has taught us that, well, most doxorubicin cardiotoxicity is probably irreversible. It's a type 1 agent. And that's because people were not detecting it in time and people were not treating it in time. And in the real world data, fast forward to 2015, when we knew how bad doxo was and the dose relation to it and the need for early treatment, this is real world data coming out of breast cancer treatments out of Cardinal et al., who has published some of the seminal trials in doxorubicin and anthracycline cardiotoxicity. And we've seen that majority of the doxorubicin CTRCD occurs in the first 1 year. So had this patient in 2017 just got echoes and cardiology follow-up till 2018, we probably would have detected this cardiotoxicity earlier. And had we started just basic ACE inhibitors and beta blockers, and two papers from Cardinal et al. Have shown just intervention with enalapril or beta blocker like carvedil or bisoprolol is usually sufficient in reversing anthracycline cardiotoxicity. And most of them, even if the LVEF is less than 45%, 64% of these patients, if you initiate treatment with ACE inhibitors and beta blockers, will reverse their cardiomyopathy within 2 months post chemotherapy. Versus if you wait, and if you see in this graph here, versus if you wait beyond 2 months and you're taking heart failure therapy to extend beyond 6 months or higher, this LVEF, if you see this graph here, is probably never going to normalize. Whereas, we look at it as a rule of thirds. If you initiate treatment in time for these patients with doxorubicin, anthracycline cardiomyopathy, these patients have a very good chance of not just more than 50% recovering LVEF, but more than half having at least some improvement. And we usually follow a rule of threes that if you initiate treatment in time, 1/3 will probably have a complete recovery of LVEF, 1/3 will improve, but stay in the mid-range, and a very small subset of less than 1/3 will probably stay in the bad category. And so the ESC guidelines for anthracycline-related CTRCD, whether you're asymptomatic or symptomatic, initially, basically, whether it's mild, moderate, or severe, tells you to basically start heart failure therapy as a class 1, including ACE inhibitors and beta blockers. And here's the key, and we all know that we have data in treatment of these patients, but the question there is, do we stop the anthracyclines in these patients? And if you are symptomatic and have more than moderate CTRCD, or even if you're asymptomatic and more than moderate, you basically want to stop the anthracyclines at that point. What about prevention, right? So we have smaller trials across all the different anthracyclines of using a lot of drugs, including ACE, ARBs, and beta blockers. And there's probably one class of drugs where there has been primary prevention data. So this is not our patient, but had we probably initiated this patient on an ACE inhibitor or beta blocker for her hypertension, for example, because she would have been a class A heart failure, maybe this patient would not have come to the point of the 40% EF that she had now presented herself with. And we also know from the PRADA trial that primary prevention, even ARBs such as candesartan, have also a cardioprotective effect in primary prevention. And now we have a PRADA 2, which is ongoing and will probably be published in 2025, about the role protective effect of sacubitril and valsartan in anthracycline prevention of cardiotoxicity. There have been retrospectives of SGLT2 inhibitors and a cardioprotective role in anthracyclines. We've also submitted an IRB for using SGLT1 and 2 with sotagliflozin for cardioprotective role in anthracyclines. And there have been retrospectives with statins as well, but which have across the board shown a cardioprotective effect in anthracycline cardiotoxicity. But we've had 2 prospective randomized control trials with statins, one showing no benefit, which was the Prevent 2022 trial that came out 2 years ago, showing that these were low-risk patients who had received less than 240 milligrams per meter square cumulative dose and were randomized to placebo versus 40 milligrams of atorvastatin, but this did not show a reduction in decline in LVEF. But the 2023 trial with STOP CA showed that the same dose, half patients, men and women, both randomized to atorvastatin 40 versus placebo, did show a prevention of cardiotoxicity occurring less in the atorva cohort versus the placebo. And the key here is, and here's the difference, right? What was the difference between this earlier trial, the Prevent 2022, versus the STOP CA with using the same dose of atorvastatin, is that these patients received a much higher dose. These were leukemia lymphoma trials, and this was mostly breast cancer patients. And leukemia lymphoma trials usually use a much higher 300 plus milligrams per meter square of anthracycline. So really, probably we were touching a low-lying fruit in Prevent 2022. And when we are actually coming to nuts and bolts of higher doses of anthracyclines, probably the cardioprotective effect of statins is probably much more evident in these patients. Spironolactone has been shown as well in retrospective studies to have a cardioprotective effect. And before I jump on to specific beyond GDMT cardioprotective mechanisms of anthracycline toxicity, I just want to quickly show you the slide of how really does anthracyclines cause cardiotoxicity. And really, the jury's out there, which is the mechanism, but really there are about 5+ mechanisms of cardiotoxicity. And without boring you with this basic science slide, it all depends on how, first of all, the doxorubicin enters into the cardiac myocyte, and it just cannot enter without lipid peroxidation. And this it does by what we call as ferroptosis. It combines with the ferrous moiety, and it really needs iron to combine with it and make it be able to penetrate into the cell membranes of the cardiac myocyte. And once it does that, this unholy matrimony of semiquinone, which is a combination of doxorubicin with ferrous, is a terrible molecule that can enter into mitochondria and cause mitochondrial damage, which will then translate into energy depletion, apoptosis, free radical generation. It will affect the contractile apparatus. And more importantly, it gets into an unholy matrimony with topoisomerase 2. And this is important. This is important because anthracyclines, normally when they combine with topoisomerase B in this cardiac muscle, then leads to, we know that the topoisomerase B is present in all our cells, in normal heart cells, and it is important for normal DNA, repair, etc. But when doxorubicin combines with the topoisomerase 2 molecules, which is present in normal heart cells, it leads to DNA double stranded breaks, free oxygen radical species generation, which causes cell death, apoptosis, and mitochondrial dysfunction. But if we use a molecule which is particular to cardioprotection and anthracyclines called dexroxazone, this can then, by competitive inhibition, leave topoisomerase B unavailable for the anthracyclines to combine with, and therefore this entire cascade will get interrupted, and this topoisomerase B will not be available for causing DNA double-stranded breaks and hence cell apoptosis, mitochondrial dysfunction, and cell death. And we've seen this translating into clinical trials where even doses, for example, our patient who would be receiving more than 400 milligrams per meter square of doxorubicin, if we combine it with cardioprotection with dexroxazone, then we can cut down the cardiotoxicity to 1 compared to similar doses that we would give with doxorubicin being 5 to 10 times more cardiotoxic in terms of CTRCD. So why do we not use it, right? If dexroxazone is such a fabulous wonder drug, why do we not use it? We know that from studies that, it can cut down anthracycline cardiotoxicity, the relative risk reduction up to 79%. But here's the catch. Most of this data is from pediatric leukemia, lymphoma, sarcoma studies. And, they use a high dose. This is not like our patients. These kids get high doses of doxorubicin with a much less decline in LVS as we see in our adult patients. And not just that, studies have shown that in kids, when we use dexrazoxane, the cardioprotective effect lasts till up to 20 years, and this goes on to protect them even till their adult years. Unfortunately, we've had only 2 adult randomized controlled trials in patients with breast cancer, et cetera, and which have also been very positive trials in prevention. But here's the problem, that there were, some very small trials, as well as there were about 3 small subsequent trials which were not very well done and were not randomized, and a 2022 Cochrane database, which basically shows that it's good to use, but they have not been well-designed trials, as a result of which the FDA, since the early 2000s, hasn't changed its stance in the use of dexrazoxane and has reserved it only for patients who are going to get a dose of more than 300 milligrams per meter square of anthracyclines. And the ESC guidelines kind of confirm that it's only a class 2A drug, recommended only if you're going to cross 250 milligrams per meter square dose, or it's a subsequent exposure to anthracyclines like in our patient. And it's probably not for all comers, even if they're high risk. And it's not for patients who have a baseline cardiomyopathy, not having received anthracyclines earlier. And it's interesting because so far, if we actually look at all the randomized control trials in anthracycline cardioprotection, And this is elegant editorial in JACC Cardio-Oncology that was published earlier this year that showed that we're looking at using candesartan, beta blockers, statins as for the STOP-CA trial. And all of these patients develop very little heart failure, even with the use of the cardioprotection from statins and beta blockers and ARBs. But look at the dose of anthracyclines that these patients use, right? They were not even very high dose of anthracyclines, and they developed very little heart failure. But the real robust data comes from much higher patients that were used in doxorubicin, and these patients received a cumulative dose which was higher than 300 milligrams per meter square with much less heart failure. And so if we really have to look at which is more cardioprotective, the biggest data is coming from dexrazoxane, even though these patients, even though the ESC as well as the FDA has not open label approved dexrazoxane for cardioprotection across the board. I also want to touch on another molecule, another form of doxorubicin, which is called Doxil. And Doxil is basically the doxorubicin core nucleus, which is basically covered in a liposomal bilayer. So what it does is makes it as a big molecule. And what the big molecule is able to enter into the preformed blood vessels of vasculature of cancer cells. But because it's a bigger molecule, it does not penetrate into the formed smaller vascular beds of the heart, and hence the penetration into the circulatory beds of the heart is much less. And we have meta-analysis from Rafiat et al. That showed that basically doxorubicin has a less cardiotoxicity compared to similar doses of doxorubicin in meta-analysis. And that might be another cardioprotective anthracycline-specific approach to take, that not only can we give them Zinacard or dexrazoxane, but maybe we can change the way we give doxorubicin to these patients who are high risk. So looking into what the ESC recommends for anthracycline CTRCD, we can, yes, prevent it by cutting down the use of the dose of these drugs, using ACE inhibitors, ARBs, and beta blockers. We don't have good protection from RNEs and SGLT2s yet, but the data is out there. But again, you see this, they classify it as a class 2A cardioprotection. Dexrazoxane use and liposomal anthracycline, just Doxil, as I showed you, also comes in the class 2A for cardioprotection, and statins as well from the STOP-CA trial. How should these patients be monitored? For example, our patients with very high risk should, of course, have a baseline EKG, transthoracic echo, and baseline cardiobiomarkers, but should also then, with every incremental dose of more than 50 milligrams per meter square, should get an additional echocardiogram, which should not end till the first year after treatment is over. Because remember the data that I showed you from Cardinal et al., 98% of worsening LVEF or initial cardiotoxicity from anthracyclines will occur in the first year. So don't let your patients out of your sight after they've completed anthracyclines for the first year after treatment. So what are the future directions, since this is a 2024 talk? Let's not forget the genes. And we get this from the childhood leukemia lymphoma trials. And remember, I told you that these patients, our kids, have received a much higher dose than 300 milligrams per meter square. And we saw in childhood leukemia lymphoma trials that, there were patients who had very lower doses of doxorubicin, much less than 200 milligrams per meter square. And these patients had developed cardiotoxicity despite low dose. And there were controls who had normal LVEF despite being challenged with very high doses of doxorubicin. So these patients were then had exome sequencing, and they basically saw that 90% of the controls, the ones who developed, did not develop cardiotoxicity despite having high dose of doxorubicin, had gene variants that protect against cardiotoxicity. And this was the beginning of the thought process that sometimes it's not even the dose, it's not even the risk factors, it's not even hypertension control, radiation, all the other conventional risk factors that the HFA-ICOS addresses, but maybe it's in our genes that these patients have cardioprotective or lack cardioprotective genes. And really, there was this elegant paper about the functional validation of doxorubicin-induced cardiotoxicity-related genes in mice models, where 26 genes were knocked out in these gene models that we thought associated with cardiomyopathy. And this led to pluripotent cardiomyopathy to develop when they were exposed to doxorubicin. And this could be not just understanding, but mechanistic targets for development of cardioprotective drugs, because we know the genes that cause susceptibility to doxorubicin-induced cardiomyopathy, and now we just have to find the drug targets targeting these genes. There's also emerging data about remote ischemic conditioning in mouse models that once, we basically in these mice models in a limb in one of the limbs of these mice, they basically caused a rotating ischemia reperfusion by basically causing constriction and vasodilation. This constriction, vasodilatation mechanically in one of the limbs, and those mice that had been exposed to remote ischemic conditioning by this it's like cyclical constriction and vasodilatation of their limbs actually withstood doxorubicin in the same dose much better than those mice that just received doxorubicin without remote ischemic conditioning. And so really, this is an elegant paper. If you have to read one paper for preventing doxorubicin cardiotoxicity, you should read this one from Cardinal et al. And Jack Cardio-Oncology this year, that yes, we do recognize now that there's genetic predisposition, age, and other cardiovascular risk factors, radiation therapy, and other cardiotoxic therapy that contributes towards anthracycline cardiotoxicity. But the cardioprotective strategies, including ACE inhibitors, beta blockers, plus the rest of the GDMT, which is being studied, changing the way that we give anthracyclines and dexroxine can protect against anthracycline cardiotoxicity. If we are unable, so for example, our patient went on to develop worsening heart failure and landed up in your ICU and needed a heart transplantation despite the best of our cardioprotective treatments and GDMT, how do they fare well? Should we be holding back? And of course, she has active malignancy and would not be an active candidate for heart transplantation. But if she was a cancer survivor, we've seen from the UNOS registry data that anthracycline-induced cardiomyopathy patients are actually younger, and most of them are women. And they tended to have LVAD use less than those from other cardiomyopathies, but their survival is similar to other dilated cardiomyopathy and ischemic cardiomyopathy heart transplant patients. They should not be excluded and should not be treated any differently from other heart failure patients reaching and needing heart transplantation. The only difference would be that, interestingly, the LVAD used in anthracycline cardiomyopathy, was the survival was similar to other DCMs and ICMs needing mechanical support, but somehow their RVs do not do as well compared to other dilated cardiomyopathies, and they needed more RV assist support, and they had a little bit of an increased bleeding risk, even though they had survived their cancer. And in fact, it's interesting that, that even though most of anthracycline cardiotoxicity has been described for left heart failure, LVADs were needed more for RVAD support in anthracycline cardiomyopathy. And we actually have submitted this case report of isolated right heart failure with severe pulmonary hypertension associated with doxorubicin without left heart failure. So even though the RV is not a usual target for anthracyclines, be aware that it's a rare but can develop isolated right heart failure with anthracycline as well. So coming back to our patient, we did, of course, start her with GDMT in multiple telemedicine visits, and that's the key. These patients don't have much time because they have to receive their treatment. So these are not patients that can be left for, follow-up, a lazy follow-up. Her EF did improve. And this is the second part of how these patients are different from other heart failure patients, is that you have to have a multidisciplinary discussion with the oncology, the oncosurgeon. And we basically decided that, hey, can you use Doxil instead of doxorubicin? Is this going to cut down your efficacy for your intended cancer, which in her case was uterine cancer? And they said, yeah, Doxil is going to work just as well as doxorubicin. We do not have a problem using dexroxane prior to each cycle, which is what we did. We closely monitored her with cardiac biomarkers. We got her an echo initially. We did it pretty frequently, and then we moved to 3 monthly echoes. And she completed a full year of treatment with a second 700 milligram per meter square of treatments. Jumping ahead to HER2-targeted treatments, which is Herceptin, Kanjinti, Phesgo, and HER2. These are HER2-targeted treatments that you also hear of. And so if this patient was going to be challenged with trastuzumab instead of anthracyclines, how would it be different? Because the mechanism of trastuzumab cardiotoxicity is completely different because it acts through HER2 upregulation. And it is in most cases reversible. So, well, if it's most cases are reversible, why is it that so far data shows that cardiac event rates, including heart failure, when patients exposed to trastuzumab can be as high as 30%? And you might say, wow, this is like as bad as the earlier slide you showed us with anthracyclines. That means this is just as bad as anthracyclines. Well, here is the key. 65% of this data of patients developing up to 30% heart failure was patients treated with prior anthracyclines. And we do see that isolated trastuzumab, which in current day practice, most breast cancer treatments are without anthracyclines, is actually very rare, less than 5%. And so it is a different beast. It's a different cardiotoxicity. It's more reversible. And if patients have not been challenged with anthracyclines prior to trastuzumab use, the cardiotoxicity of these patients is actually much rare, less than 5%. And therefore, we do not usually hold back trastuzumab for three reasons. A, as I showed you, it is rare for trastuzumab cardiotoxicity if it's just in isolation, it's less than 5%. B, if you have a HER2 positive cancer, which are most of the breast cancers that it is used to, and there are some other malignancies that have HER2 positive markers, trastuzumab interruption will increase the recurrence of the cancer. This is such a targeted treatment for these cancers that if you withhold targeted treatment, the cancer will come back with a very high degree of recurrence, and the patients succumb to their malignancy within a matter of a few years. So the impact of you holding trastuzumab for a potentially reversible cardiomyopathy is huge. And also, we have two smaller trials, which I want you to sort of spend time on a little bit, called the SAFE Heart trial and the SCHOLAR trial, both published in 2019. And it basically showed, I agree they were smaller trials, but these were patients who developed asymptomatic LV dysfunction between 40 to 49%. So it was the HFMAFs. And these were patients who started on ACE inhibitors and beta blockers and looked at very carefully by cardiologists. And less than 10% of these patients had a further decline in LVEF or symptomatic heart failure. So the bottom line is that if you have to challenge these patients with trastuzumab, even with pre-existing LV dysfunction, like our patient was, you can start GDMT and safely expose them to trastuzumab with close follow-up, and don't deny them the trastuzumab, unlike anthracyclines, which can cause worsening. And so I just want to show you the difference in the ESC guidelines for anthracyclines versus trastuzumab, where most of anthracyclines are recommended hold, discontinue, discontinue. But in CTRCD, because of trastuzumab, you're able to, in most cases, continue with your treatment if it's mild to moderate with close monitoring, with the only exception being if you have severe less than 40% decline or symptomatic heart failure, where you would interrupt treatment for heart failure therapy in trastuzumab. So the difference in management for anthracyclines versus trastuzumab. Jumping right ahead to a lot of admissions to ICU for immunotherapy, and I'm going to quickly present a case of this gentleman who presented with treatment for non-small cell lung cancer with Keytruda and nivolumab, a combination treatment with PD-1 and PD-L1 immunotherapy, presented with heart failure. PE was ruled out, CAD was ruled out, and with catheterization. And while the patient was getting an echocardiogram, goes into complete heart block, as in the EKG here. And so the question here is, what do you do next, and what do you think the pathology is? And I really want to emphasize that immunotherapy with checkpoint inhibitors have been around not since since Jimmy Carter, who's still living at 101 today and voting in the presidential election still, is alive today thanks to Keytruda or pembrolizumab that he was given for his brain cancer in August 2015. And there's a slew of checkpoint inhibitors that have been approved since then, 15 plus counting. And so far, they've been approved for ostensibly every malignancy, not just metastatic brain cancers and melanomas, which it was initially in 2015, but 40% of current US cancer patients currently qualify for an FDA-approved indication for ICI immunotherapy. So we are moving not just from chemotherapy cardiotoxicity, but we need to know our immunotherapy because now it's about cardio-oncology, but cardio-immuno-oncology. And really the immune effects of these ICIs is everything from cerebritis to toitis, as I say. And we have seen that even though the incidence of cardiotoxicity and myocarditis in phase 2-3 trials is very low, less than 1%, in our registry data that we've been collecting since 2016 onwards and initially published in 2018, myocarditis by ICIs is much more common reported, up to 2%. And it is a difficult diagnosis to make because not all of it presents with a decline in LVF by echo or MRI. But here's what makes it a little bit easier and has certain characteristics that I want you to look out for. Most ICI myocarditis from checkpoint inhibitors occurs in the first 3 months of exposure. 90+% cases occur in the first 3 months. And most of them occur with either PD-1 inhibitors or because of a combination of 2 checkpoint inhibitors. Your best tools with a good sensitivity are an abnormal EKG and a troponin. So if you have a normal troponin and some mild EKG changes, it's not myocarditis. You have to have both of the troponin and EKG changes, which will be abnormal in majority of your cases. Of course, the gold standard is biopsy, but we'll discuss not everybody is an all-comer for biopsies, and we have to kind of make the best choices for how we will diagnose it. EKG changes are present in majority of the patients, as I showed you, in 90+% patients, and we've presented a lot of data about the EKG changes in ICI myocarditis. And echo in ICI myocarditis, interestingly, 60% with ICI myocarditis had normal LVEF and echo, but GLS, the strain imaging, declines in majority of the patients who develop ICI myocarditis. So I know when we call the fellow or the echo attending in the middle of the night to assess the LVEF, do get a strain because your EF might be completely normal in these patients presenting with ICI myocarditis with just a troponin and EKG changes, but their strain imaging might show subclinical LV dysfunction and declines in majority of the patients and has bad prognosis. In terms of MRI diagnosis in ICI myocarditis, again, this is from our registry data that showed that the mean LVEF was actually normal in 61% of the patients had an EF of 50% or more. And most of them, by the old criteria, by the old Lake-Louise criteria, had late gadolinium enhancement in only 48%, which means if you're going to hang your hat on just late gadolinium enhancement and you're not looking at T1 times, you're not looking at ECV, you're going to possibly miss myocarditis by MRI standards. And also you have to know that the LGE might not develop in the early phases of ICI myocarditis. So if you're rushing to do the MRI in these patients in the first couple of hours or days, you might miss the myocarditis because LGE is probably not developed by then as well. So yes, we agree, the diagnosis of ICI myocarditis is difficult, but if we combine patient symptoms, so here's the key, you have to be cognizant of any change, and I know these patients are already dyspneic and fatigued, etc., but be cognizant of any new change in patients on ICI treatments, be cognizant of EKG changes in troponin if they present with any change in their symptoms and with positive biomarkers. And here are the challenges that, of course, the gold standard is a biopsy. We know that. But if we apply the modified Lake-Louise criteria, which includes T1 times and ECV and does not just hang its hat on late gadolinium enhancement, we will get a more specific diagnosis of myocarditis. And in combined with symptoms, signs, EKG changes, and here is the important part, non-cardiac adverse reactions. If we put together all these diagnostic considerations, we might not miss any of these diagnoses of ICI myocarditis. And I really want to bring to point, because in the last 6 months to 12 months, we have had some overlapping cardiotoxicities in Mount Sinai ICU itself. And we've had these 4 cases, and all of these we've submitted as case reports or abstracts in different journals and meetings. And we've had ICO myocarditis where we had biopsied a patient and it turned out to have TTR amyloid. Or we thought it was ICI myocarditis, but the patient also received 5-FU and there was an acute cardiotoxicity overlap. And the MRI which showed late gadolinium enhancement, which we didn't know was because of the first challenge of ICI versus 5-FU. We had ICI myocarditis with an LED lesion, 90%, with concomitant CAD, and we didn't know where the tropes and the EKG changes came from. We had ICI myocarditis given together with anthracyclines with an abnormal MRI, EKG, and cardiac biomarkers. And again, difficult to tease out whether the overlapping syndromes were because of ICI or because of the other offending drug. And really, and how it helps you, how can we pinpoint other than biopsy, MRI, etc., which, as I said, could be common with other cardiotoxicities, is look out for other immune-related adverse effects. And here's the key, right? And especially if you have overlap syndromes, if you have cortisol levels that show adrenalitis or CPK levels that show myositis, or a patient is developing an myasthenia gravis-like syndrome, or the triple M syndrome, as we call it, or a hepatitis kind of syndrome as well. All of these will show myocarditis, will show concomitant cardiotoxicities from the patient, and will be suggestive of ICI myocarditis versus the other possible differential diagnoses as well. And so what do you do when you see that these patients have possibly developed ICI and myocarditis? And here's what you do, right? So this is the key part. You should be challenging them with pulse steroids. And you, of course, they should ideally be in an ICU setting. And if they are not responding in the first 24 to 48 hours with steroids, if they do, we usually typically do a steroid taper of 4 to 6 weeks, and also assess them with periodic imaging and cardiac biomarkers before completely discontinuing the steroids. But if they're showing unstable arrhythmias, hemodynamic instability, the cardiac HS troponins are not trending down, you need to escalate it to a higher level of care, and you need to consider a second-line immunosuppressant in these agents. And I'll talk a little about what that second-line agent should or could be. And for example, we've presented this case in ACC as well of a triple M syndrome in a patient receiving nivolumab, which was a cardio-oncological emergency that we treated not just with steroids and Plex, but we added a second-line agent. And so the diagnosis of myocarditis, though very challenging, the ICOS actually gives a consensus document in how to diagnose it, with, of course, the biopsy being the confirmatory test. But of course, we don't have to jump to a biopsy for every patient unless there's an overlap syndrome like I showed you, or if the clinical diagnosis cannot be made with one major and your 2 minor criteria, with a diagnostic cardiac MRI, which would be the major criteria, or 2 minors, which would be a classical clinical syndrome, or presenting with a ventricular arrhythmia, decline in LVEF, other adverse immune-related adverse events, or a suggestive MRI, which is equivocal. So you need 1 major and 2 minor, or a cardiac biopsy for the diagnosis of myocarditis. Add to it the modified ICOS criteria. Like I told you, majority of the patients will be presenting with myocarditis in the first 3 months. So we add this criteria of 3-month presentation as a third minor criteria, the specificity of you being sure that this is ICI myocarditis goes up even more. And the suggested surveillance for checkpoint inhibitors, everybody should, on a checkpoint inhibitor, and we reaffirm to our oncology patients and providers that they should all get a baseline biomarker, as well a possible transthoracic echo if you're low risk, but the definite one if you're high risk. And then the subsequent monitoring is recommended only if you are a high-risk patient. The most important thing is be cognizant of their cardiovascular symptoms. So see them regularly. Keep the ICI and myocarditis on top of your differential diagnosis. They present with different symptoms from their baseline. Not everybody needs EKGs and cardiac biomarkers unless they are high risk. But you do want to follow these patients clinically very closely. And if you assess that there's been any difference in their clinical status, you do want to get an EKG and a troponin and then escalate it to whether or not they have ICI and myocarditis or not. And the importance of this is key because early diagnosis means that they can have a case fatality of in this series of up to 30%, but we know that overall in our data, it has shown that the MACE, if you delay treatment, can be as high as 85% if there's a delay in giving them steroids beyond 72 hours versus it can bring it down, the adverse cardiovascular effect, including cardiomortality, can be brought down to 22% if you hit them with bulk steroids. So when you guys talk to me over the phone, and especially the fellows, I'm like, listen, we have a suspicion. We're going to do the rest. We're going to punch in the HFA ICOS criteria or the modified criteria. We're going to work on the MRI. We might consider a CTA or a cardiac cath to rule out concomitant CAD. We might consider a cardiac biopsy, but till we're doing all of that, initiate the pulse steroids earlier than later. What about the refractory one? So what if these patients don't respond? The cardiac troponins are not responding. They go into complete heart block like our patient did. What is the second line treatment that you want to hit them with? And do you want to hit them with Cellcept or infliximab or ATG or IVIG or plasma exchange, especially in our myasthenia patients, where we want to spare them steroids? Because also remember that triple M syndromes and myasthenia presentations, hitting them with high dose of steroids can actually paradoxically worsen their myasthenia as well. So you probably want to give a steroid sparing second agent. And I want to show you the emergent data on that. And that's for the CTL4 agonist immunoglobulin called abatacept, which has been studied in mouse models. And we see that CTL4 is actually cardioprotective. So in mice models, if we knock off CTL4, these mice went on to die from cardiomyopathy from ICIs. So if somehow we can restore and protect CTL4 and give them CTL4 immunoglobulins, these patients can be protected. And so there's been retrospective studies studying CTL4 agonist abatacept along with jakafi in patients who are presenting with triple M syndrome, like our patient. And there is currently a randomized controlled trial occurring in about 50 medical centers throughout US, Canada, and beyond. We are not one of the sites, but we will know what the upcoming data is on these. Jumping straight ahead, what do? Can we re-challenge these patients once they've presented? Well, it all depends on how bad is this ICI myocarditis, and really, if it is just a 0 grade, which with a mild LV function decline, we can probably re-challenge them, as we know from this MD Anderson trial that came out, which based it on biopsy data. And they basically saw that those who had low-grade biopsy findings can possibly re-challenge with no worsening and no recurrence of ICI myocarditis, versus the ones like our patient who completely came in with complete heart block and heart failure probably should not be re-challenged. And let's not forget, let's not just look at the trees, but look at the forest beyond. And this is the emergent data from ICI that, yes, you might hit them with steroids, abatacept, reverse the acute cardiotoxicity, but don't forget that this T cell activation and the inhibition of PD-1, PD-L1, and the CTL4 pathways actually has been shown in mice as well as human studies from RCTs, as well as retrospective studies, imaging studies, with imaging, that the plaque burden increases over the long term as much as 2 years, and the aortic and coronary plaque actually goes up with less calcium, more lipid-rich plaque, and they have a 3-fold higher cardiovascular events over the next 2 years. So don't just discharge them from the ICUs. These are patients that should be followed by cardiology for future events as well. I'm going to jump straight away to CAR-T, which we are a big center for. And I want to tell you that CAR T cell therapy, which is used in myeloma, leukemia, lymphoma studies, are basically very smart T cells that are associated with CRS syndromes. And the reason why we have very little cardiovascular effects in the Mount Sinai data that we presented in several presentations is that we intervene on CRS early. And we give tocilizumab for CRS very early when they develop CRS with CAR T cell therapy, and we have very low cardiovascular events. So again, our oncology colleagues know how to do that. But if you get any of these patients developing CRS after CAR T and then land up with you, please give tocilizumab as necessary and as early as possible to prevent cardiovascular events. And let's not forget other causes of heart failure in oncology and Takotsubo's that occurs in cancer patients as well. And I'm going to jump ahead really quickly to 5-FU cardiotoxicity because I have 1 minute to touch on the other cardiotoxicities. And I want to jump ahead to this slide for 5-FU cardiotoxicity that might land up in ICU setting. And do not take 5-FU chest pain for granted and just give them vasodilators because they might present with direct cardiotoxicity. They can land them into VT, sudden cardiac death, and cardiac arrest. So yes, if they just have chest pain, you can definitely do an ischemic evaluation, refascorize them, put them on calcium channel blockers and nitrates, and do not give them the 48-hour bolus that they get at home for 5-FU. You can give them the boluses in a setting, in a 1-hour slow infusion in a telemetry setting, but do not send them home with a 48-hour bolus because that is the most cardiotoxic and as cardiotoxic as capecitabine, which is the oral drug. So don't think it's an oral drug and less cardiotoxic. Also be aware that if they present with 5-FU acute cardiotoxicity with acute cardiomyopathy and arrhythmias, you have to hit them fast with 9 doses of uridine triacetate as well. And do not hold back PCI in patients who are presenting with ACS. In cancer patients, just make sure you're giving them the right strength, the right stent so that you can minimize dual antiplatelet therapy. And I'm going to skip ahead. I'm going to skip the VTE and go straight ahead to the future. That yes, we know the role of NOACs and low molecular weight heparins, but let's not forget that around the corner are going to be the factor 11 inhibitors, which are going to make patients bleed less as well as thrombose less. And that is the future. A lot of QT prolongation in our patients, a lot of AFib in our patients. And the CHA2DS2-VASc score in cancer patients does not survive. And
Gagan,
I will
I'm
it
so
right
sorry
there.
to
Yes,
interrupt you, but our future is at 2 p.m., another meeting, and I'm
sure.
actually quite short of breath listening to this amazing breadth of coverage for cardio-oncology. It's probably a 2-year fellowship by now that you've
It is
given
a
us.
1-year fellowship. Yes.
You've
It is
given
a
us.
1-year fellowship.
Yeah.
But for those that I did not cover, the 2002 pocket guidelines are there, and be happy to share my slides as well for the things that we haven't covered. But usually I cover this talk in 2 sessions, and happy to do the rest in a different one. But
Good.
thank you, and any questions if anybody might have it.
Yeah, so we don't have time for questions, but I'd like to summarize quickly by just wrapping, everything up. It's vast, but as far as the cardiology and the ICU docs are concerned, essentially there are 2 or 3 large syndrome groups. There are 4 or 5 large drug groups, and identify early, have a high index of suspicion, and a low threshold for calling one of the best cardio-oncologists in America, Dr. Gagan Sahni.
Thank you, Dr. Gidvani.
Thank you.